Good evening. My name is Stephen Reiner. I'm with the Alan Alda Center for Communicating Science, and this is Science on Tap. Tonight we're going to be talking about an extraordinarily interesting topic, and a topic that fascinates and frightens and mystifies many of us. We're going to be talking about autism. My guest tonight is Dr. Matt Lerner, who is the Assistant Professor of Clinical Psychology at Stony Brook University and runs something called the Social Competence and Treatment Lab. We're going to be talking about just what that is in a couple of minutes. As most of us know, there's been a 10 times, 1,000% increase in diagnoses of autism over the last 40 years. 1 out of every 68 children in the United States is now diagnosed with autism. It is an important public policy issue. It's an important mental health issue. It's an important issue in our educational system. So I want to welcome Matt, and I want to start out by asking you the very basic question: what is autism?
So autism is defined by the American Psychiatric Association as a developmental disorder affecting really now 2, used to be called 3 core domains. The first domain is social communication, so the capacity to engage in a reciprocal dialogue, develop and maintain relationships, which, as we'll be talking about, is very central to a lot of the questions we're asking nowadays. And read and process social information, sort of it's the first one. And then the second one is this domain of what's called restricted and repetitive behaviors or interests, right? So sort of either a hyper focus among some people on the specific topic and maybe having difficulty moving away from that, or engaging in movements that the term that's used is stereotyped. We don't mean stereotyped like, racial stereotyping. We just mean sort of repetitive in a very specific kind of way. So at base, that's what we're talking about.
And when we talk about autism, and indeed the latest definition by the American Psychiatric Association talks about a spectrum, that autism is not just one point, one thing, but it goes along a line of differences. So talk to me about what the spectrum is, because people who are considered autistic can be people who are sort of completely locked up and sort of unable to really at least visibly deal with the outside world, to people who are only maybe marginally less able to read tones of voice or facial expressions or socially interact. So talk about that spectrum.
Sure. Historically, we really were focusing, more than, say, 20, 30 years ago on kind of a narrow slice of the spectrum. And over time, really, 2 things have happened. One is that many of those original kids grew up and turned out to not quite be so selfist as originally thought. Seemed to have more of an ability to communicate, maybe still had challenges with it, but many of them started to and continue to be able to do so. And then sort of concurrently, just looking at new populations, more and more people were noticing that some of these same features, these sort of difficulties, reading perhaps social cues, or understanding somebody else's perspective, or being able to sort of initiate and maintain interactions in a way that is really kind of dynamic and flowing back and forth, that those features start to look more and more common the more you look for them, and you start to notice that they exist in lots of people. And that's sort of what we mean by the spectrum, right? That there is this range where, and in fact, there's lots of discussion nowadays that some people have, and many people have some of these features some of the time, right? There are some times when you are really excited about something, really interested in something, that maybe you don't notice that the other person is sitting there, like maybe right now, having a beer,
Right.
Not really paying attention, but you miss it, right?
So to what do you attribute the tenfold, 10-time increase in diagnoses? We hear this again and again and again. Is it just that we're looking for it more, we're identifying things as autism that 20 years ago we just simply didn't identify as autism? Or is there really something going on that we don't yet understand that is causing more and more people to manifest some of these behaviors?
Yeah, so it's a good and complicated question, it turns out. And to put it really briefly, there are 4 things that could be responsible for this increase. One of them is our changing diagnostic categories, right? So before 1994, you had to have, for the most part, an intellectual disability, meaning an IQ below 70, to, in many cases, even be considered on the spectrum. That changed with DSM-4 and has maintained in DSM.
That's the Diagnostic and Statistical Manual,
Yes.
which is the Bible of the psychiatric world.
Exactly.
And if it ain't in there, you're not going to get reimbursed by your insurance.
That's right. And clinical and medical providers may not be able to communicate about you as well. So that's sort of what it's used for. So that change happened, and that indeed brought more people into the spectrum. The second piece is broader awareness. So, this prevalence thing has a reciprocal relationship, right? So back when it was a few in every 10,000 kids, not only did most people not see it, most medical providers weren't even necessarily trained in it. I've spoken to pediatricians who were trained in the 70s, and they said, oh yeah, I heard about autism in medical school for one day on the last day of my 4th year of medical school in a class called Disorders You'll Never See. And it was one among them, right? And that's no longer the case. So that's the next one. The third one is something called diagnostic drift, which is that, in the real world, when somebody's actually trying to parse out, does this person have autism or maybe something else, there are these tendencies. If somebody's on the cusp, there are sort of tendencies to fall to one side or another.
So there's a bit of overdiagnosis.
I wouldn't call it necessarily overdiagnosis, but at least more of a tendency to fall on the side of autism as opposed to what else they might be considering. And the fourth one, the last one of all those 4, would be a true actual increase, literally more people. And it turns out that a lot of the increase that we've seen can be ascribed to these first 3 things. Not all of it. There does seem to be some increase afterwards, and we don't know really where it's coming from and why. And much smarter people than myself are looking into trying to understand where that comes from. But what we can say is that a very large amount of that increase comes from those first 3 things.
So now we come to the first very, very big question, which of course is on everyone's mind, which is the question, well, what causes autism?
In terms of causes, we do know that at least some cases are genetic. They're not. We know that there appears to be at least as much as up to half of the cases of autism seem to have some link to some genetic predisposition, perhaps.
And what about environmental causes?
Right. So that's the other side, and we don't know about that yet. If I had to say what the sort of state of the art is pointing towards now, there seems to be something prenatal, maybe in the 2nd trimester. That seems to be where we're looking. But that's, again, still early days. As you said, there's much more that we don't know about autism than that we do.
Well, we're going to start to get to what you do in your lab, but before we get there, let's talk about what's being done out there to help.
Sure. So one of the things we do seem to know about autism is that early intervention helps. Doing a thing early, and what that thing is we'll talk about in a moment, but doing something earlier helps. In fact, one of the reasons, for instance, that there's a big push for earlier and earlier identification, it's not just because it's nice to know earlier, though certainly it's helpful in terms of sort of framing one's plans and goals as a parent. but also because we really do know that the earlier you intervene, it really does seem to change that trajectory in terms of outcomes. So what do we mean by intervening?
Exactly.
So there's probably two mainstream approaches that are used. The most widely known one in sort of the general public is what's called applied behavior analysis, or ABA. And applied behavior analysis is an approach that involves, maybe sitting across from a person. This is one form of it called discrete trial training, where you say, okay, I want you to, practice handing me your glass. And maybe I, say, Stephen, hand me the glass. And every time you do, I might reinforce that and give you, M&Ms or praise or something that you want. And the idea is to sort of do it a lot and intensely and over again in a systematic fashion, and using sort of basic principles of behaviorism, increase more of what you want to see. That's one approach. The other approach that's been around for just as long goes under many names, but in general what we're talking about is an approach that's more naturalistic. So it's rather than sort of saying, okay, let me create an environment where I'm going to create an opportunity for you to, for instance, offer me a glass.
And do it again and again and again, and pattern and pattern.
Yeah. The now more naturalistic approaches might say, okay, I'm going to be in an engaging environment with you, like this room, and wait for you to, and try to engage with you on whatever your terms are, and then try to catch those moments when you do it. So maybe we're talking and you kind of hand me the glass, and maybe as soon as you do it, then I go, all right, great, thank you so much. I'm so excited to have that, right? And that's what you might do with an older individual who can talk, but with a younger child, you still might provide them some kind of reinforcement. But either way, it's about sort of an affective quality, an emotional trying to build an emotional connection. And
so you try to do it in the context of a real social interaction.
Yeah, or just a real walking around interaction, right? So in daycare. So those are sort of the two longest, most well-established approaches, and more recently there have been more attempts to kind of fuse them. So for instance, there's an approach called the Early Start Denver model, which was created by Sally Rogers at UC Davis, and it is now actually the largest, best designed trial of an early intervention now. Is actually not ABA and not even the other approach, which sometimes goes under the name floor time, but it's actually Early Start Denver model, which is a kind of a hybrid of the two. There is one thing that's common among any approach, almost for any age with autism, which is it's based on the notion that early on there seems to be things in the social, usually, or just general world of people with autism that catch most people's attention, but don't seem to catch their attention, or don't engage their attention in the same way, aren't as motivating. We don't necessarily know if it is an attentional issue or an engagement issue or a motivational issue, but whatever it is, there's things that are going on that other kids are doing that they're kind of missing. And so all of these interventions at base are trying to sort of turn up the volume. Apparently I shouldn't turn up the volume too much because I'm feeding back, but turn up the volume on parts of the experience of the world that they might not otherwise be hearing or catching.
And when we talk about early intervention, because I want to get to your work pretty soon, when we talk to early intervention, you're not talking a couple hours a week. I mean, you're talking about recommended many hours every week.
Yeah, the standard recommendation in the field, believe it or not, is something like 40 hours a week, which is a lot of hours.
Before we go on, because you don't work with 18-month-olds and 2-year-olds, you're working with an older population, with teens.
The mean age of the kids that I work with is somewhere around 11 or 12. Well, 11 or 12 is middle school. And we're talking about kids who already have trouble socially. And for anyone who's been to middle school,
it's bad enough.
It's bad enough as it is.
Well, aside from working with this age group, the other really important thing that kind of informs your work is this notion that when you can identify the specific kinds of autism, specific kinds of behaviors on that spectrum, you can begin to target very specific interventions. And it's not a one-size-fits-all kind of treatment plan. You're 12 years old, you have autism, all right, this is what you
Go
got.
on the shoot, yeah.
It's all very different. And in order to get there, this is what you do in your lab.
Exactly. So,
So let's take a look right now, and if you don't mind, it's going to be on the screen, if you don't mind narrating some
narrate
of
a little
it
bit.
and telling us what we're going to see, your work in the lab.
So before we start, so what you're about to see is these are not participants in my studies. These are some of my wonderful research assistants in my lab. Part of our assessment procedure in our lab is we use EEG, electroencephalogram. And so Lindsay and Jackie have put the EEG onto Arjun's head, and it has these little electrodes. They don't hurt. They are reading his brainwaves in sort of the same way, or they will be, through an amplifier.
He's getting a head massage.
So he's getting a head massage. So that's what they're doing, is they're putting in special gel that helps to make sure that we get good signal at each of those electrodes. So I'm watching that happen. The electrodes turn green on the cap. They then turn green on my display, and that says, all right, we're good to go. Then we start the task. So here we're showing Arjun faces, and he has to rate the emotion.
Happy.
So it's saying out loud the emotion.
Angry.
And now I'm reading this ribbon of brain activity that's coming off of his head while he's doing this task.
Scared.
And what we've done is we've taken that whole long ribbon of electrical signal, chopped it up into these little segments that begin about 200 milliseconds before the face and up to a second afterwards, strung them together, and then collapsed them and averaged them into this little wave. And essentially this little bump is saying, hey, I see something. And so it takes place right over the very back of the head. And that's the part that processes visual information. Then it kind of travels right around here to what we call the fusiform gyrus, which is a part of your brain that's designed, it seems like, to process complex visual information about which we are experts. And one thing that we are typically experts at is processing faces. From that area, we believe, there's this little bump that we see, which we call the N170. And people differ in terms of this. So some people are faster, so their bump might be up here, and some are slower, so their bump might be way down here. What we see is that in people with autism, this little bump, this N170, is slower, so it takes place somewhere out here rather than somewhere to the left. And what we found in our lab is that that matters. That in fact how quickly they're doing that relates to how good they are at, for instance, detecting emotions in faces. There's a similar component we see in relation to voices, and we can even use that, it appears, to predict who's going to respond to what kinds of interventions.
Well, let's just pick up on that last point, this N170. This can help you understand who's going to respond to what kind of interventions. Tell us how we get from what we just saw to that.
Yeah, to interventions, right? So we go from a little bump coming off the side of electrical activity in your brain, and all of a sudden, intervention. What do we mean by that? Well, if we think about that N170 as telling us something about how an individual catches social information when it happens, meaning how they, it's almost like in live when we're sitting right here, right? I mean, we're talking on the order of milliseconds. But if I'm a few milliseconds late and you've already kind of given me a little, eye gaze again, saying, Matt, you're going on too long. Come on, pick up the pace. Again, drinking your beer, turning away. Well, I might miss it. And if I miss it, then that's going to potentially snowball over the course of the complicated social world and make it more difficult. And so there's a framework. Mind if I talk about it for a minute? There's a framework.
I'll give you a signal when I think.
Okay, good. We'll see if I catch it. There's a framework that we can use to maybe use this to try to break down how our interventions work, how we think about them. And the framework that I sometimes use is what's called the knowledge performance distinction. And it's this idea that individuals, that perhaps one reason that somebody doesn't engage in successful social interaction is because they don't know what to do. That would be a knowledge deficit. And indeed, that's something that people talk about colloquially all the time, right? With a child who's on the autism spectrum, but maybe it does have sort of hyperverbal ability, or they say, oh, but they don't know what to do. Well, it turns out don't know what to do is a specific claim you're making about what's wrong and what to do. Well, should we?
Yeah, let's look at that first intervention, which is, and this is a series of photographs, and you're going to tell us what we're looking at.
So this is a traditional approach. So these are some of my grad students and undergrads, and they're sort of practicing out one of these interventions. So this is a very common approach. In fact, this is pulled right from a widely used manual for teens on the spectrum that says, okay, they don't know what to do. We're going to tell them how to do it. This is the rules for starting a conversation. So what Tammy and Erin, my 2 graduate students, are doing is they're saying, okay, let's talk about what you do. You say hello, or again, if you're expressing your feelings, you have to tune into your body, you have to understand what happened, and they kind of go through and they elicit examples, and then maybe they show them examples of how that works, and you sort of teach rules. And so that's a knowledge approach. And the knowledge approach is based on the idea that children don't necessarily know those rules. And it's an entirely plausible assumption. But it is an assumption that we make in the field. And so one of the things that we do also in my lab is try to test that assumption. And what we found is that there are many kids with autism who do know the rules. That actually, if you ask them, right, what are the answers to these things, they know, and they can tell you just right. And so that then begs the question, well, what's going on? I thought it was a knowledge deficit, and that informed the intervention that I made. So what do I do now? So the opposite.
So I know what to do, I just can't do it. Something is stopping me.
Yes, and that moves to what we call the performance deficit model.
So we're going to look at now this other approach, this performance-based approach.
Yes, so this performance-based approach you're going to see is going to show you some ways in which we try to do things like help kids to more quickly catch facial expressions or eye contact as they're happening, or more quickly sort of read or interpret emotions, right, which is sort of the related thing that we were able to show in the previous video, or more quickly come up with novel solutions to social problems, right? So maybe they know the rule, but they can't use it flexibly. So those things, right, catching social information, reading and expressing emotions, and sort of coming up with novel solutions are all things that are in ASD, in autism, the kinds of things they tend to have trouble with.
So let's look at this.
So what they're doing is they're trying to make eye contact, and as soon as they make eye contact, they want to clap at the same time. This game is called Round of Applause. And though my brilliant research assistants and lab coordinator are very good at this, kids on the spectrum, teens on the spectrum, interestingly, don't seem to be very good at this, at least at first. But as we do it over time, they seem to get better.
I'm so sad.
So this is a game where
I'm sad.
you say or show an emotion,
I'm happy.
like happy, as Tammy just did.
I'm so happy.
And she said so to
I'm
Jackie.
nervous.
And so what you notice is they're not expressing the emotion in the same way, and we tell them this. You show your own emotion in your own way.
Angry.
As a way to try to understand and interpret the differences in how these emotions emerge.
I'm feeling shy.
So it's not about the rule, happy as a smile. It's about flexibility and understanding that different people might express it differently. And practicing
I'm so excited.
looking for it, which can be exciting.
We have one more.
Okay,
One more.
Doing a quad in here. Do you want to take this apart?
So this is actually a variant on an improv game. This game is called Freeze.
This is a really cool motorcycle.
So they are coming up with a
I just
spontaneous
hope that we don't
scene.
get into any accidents.
I know, that would stink.
This is a video shot from my lab. We have a multi-angle camera where we're recording what's happening. So they then stop where they are. The new participant comes in, takes the position, and with action, they start a new scene.
Oh, ow.
I'm sorry.
I didn't realize I was such a bad driver.
That's totally cool. I think probably that pit that we saw over there, I saw it, but I should have told you that it was
Yeah,
there.
I totally missed it.
so Becca came in and did something new. That my lab coordinator was Becca, the one who hit the speed bump, and so she did something new. But in some ways that's the challenge, right? You have to come up with something new. But actually, in some ways, the person we're more interested in sort of helping or targeting in that particular activity is Arjun, right? Because he suddenly has to figure out I'm in a new position with a new person in a new situation, and I have to respond flexibly and appropriately. But again, it's not about rule teaching in that case, right? I mean, we are not trying to, teach kids to go around going into speed bumps, falling off bicycles. We're trying to create a venue for practicing novel responses, or create a venue for catching social information more efficiently, or for reading emotions. And so getting back to your original question, right, how does that relate to this N170 thing, aside from maybe as a measure of outcome? So what we've started to see is that when we assign kids to, so what we've done is, traditionally a lot of these interventions are kind of mixed together, right? You might go to a summer program where they do some of both of these things. So we're starting to use that distinction, that knowledge performance distinction, to take apart these interventions and figure out, all right, how are these things working? So we might assign kids to a few weeks of a knowledge approach, or other kids to a few weeks of a performance approach, and see what changes are happening. So for instance, one of them maybe works faster or works on a different process. And we also seem to see that some kids seem to do better in one or the other. So for instance, in the knowledge training approach, we found that there are kids who it seems to work well for. And the kids who it seems to work well for are kids, seem to be, as of now, research is not published yet, we're taking more data. As of now, it does seem to be that kids who score higher on a knowledge test at baseline, beginning, seem to improve more over time in a knowledge condition, suggesting it's maybe something like a learning style, right? Maybe those are kids who really, glom onto rules and say, I need rules, please help me, please give me some rules. They've taken them already, and then when they're in an environment where they seem to get them, they kind of run with it. Whereas we find that actually it seems to be that kids who have this slower N170 at baseline seem to do better in the performance condition, suggesting that maybe, again, the term we would use sort of in the clinical world is like deficit consonance, which is a fancy way of saying that's an area that's a problem for them. We're targeting that area by trying to help them to catch that information more effectively, and they seem to be improving more. Again, this is very preliminary findings right now.
Very preliminary, so the evidence about what the efficacy of these interventions are, whether they're working, depends on who they're targeting. One will work better with one group, one will work better with the other group. There is evidence that they do work.
There is evidence that they do work. So the first thing we did is a series of trials where we checked to make sure that they actually are doing something, that we're not just, taking their time and clapping at each other for a while.
So after a few weeks of pretty intensive work like this, you will see some difference.
We seem to see, so the differences we've seen seem to be evident in parent reports of behavior, teacher reports, including, at least in the performance training condition, even teachers who don't know that the kids are assigned to the condition. We also see change in some computer-based measures of things like emotion perception, so the activity that Arjun was doing, as well. And we see a little bit of evidence, and this is sort of, to my mind, the holy grail. We see a little bit of evidence already in terms of friendship making. So actually asking peers, secretly, okay, who's your friend in this group?
Well, that leads into the final question that I have for you, and then we're going to open it up to questions in the audience.
Yeah.
Which is, you've talked to lots and lots and lots of young folks who are autistic. Not in an experimental circumstance, but in conversation, what have you learned from them? What have you learned about, in a very non-scientific way, what have you learned about their world? What have you learned about the way they see the world? What have they told you what it's like?
Yeah. The first one is, one child who came to me. I use this example actually a lot when giving talks because I love it. He came to me before joining one of these groups, and he said, Matt, everyone in my class appears to be psychic but me. And that was how he was sort of perceiving the world. And we talked about what he meant, and he said, yeah, well, there'd be one kid next to me, and he kind of rolls his eyes at somebody, and the other kid goes, yeah, whatever. And I don't know what I can't figure out. Maybe I'm missing it, but I don't know, what they're doing. The first kid, I thought he was having a seizure. The second kid, I thought he was burping. And he said, I want some psychic powers. And so we started. That was a good audio effect for psychic powers. So we got. I worked with him for a few weeks, and in one of these groups, and I came up to him and I said, "So how do you feel like we're doing on the psychic powers?" And he thought about it, and he said, "I do think I have some now, but I'd like some more, please."
That is a great story.
And I think it goes to show, he was, right in that age range I was talking about, right? So this tells us something important about sort of his emerging awareness of that difference between himself and other kids, that there are things that he wants to sort of do and be that are different, and that also he can kind of assess it, right? That he was able to note, when asked at least, he was able to notice that kind of difference. Another thing that just really stands out to me, and I think it's something that we actually underappreciate about this field and this issue, and it's something I'm really wanting to make sure we focus more on in our research, especially on these groups. So I had a different kid come up to me about maybe a week into one of these interventions. It was in a summer program. He was there every day, for the week, 5-week summer program. He came up to me and he goes, "Hey, Matt, where'd you find these kids?" And I said, well, just sort of all around. They're all in different schools. Why do you ask? And he goes, "This is an 11-year-old boy." He said, "This is the first normal group of kids I've ever met." And I actually I try to keep in mind all the time, right? Because I think while we're talking about intervention, we're talking about helping. We also have to remember to respect who we're talking to and where they're coming from, right? And these kids who we're working with, it's not just about saying, you're all the way over there and I'm all the way over here and I want you to be more like me and all the other people who are over here, right? We need to I think as a basic premise, at least consider the idea that they're starting from a place that in some way might be working for them. Maybe not working as well as they'd like. Maybe they want more psychic powers, right? Maybe doesn't work as well in all the contexts. But the fact that this boy felt like these other kids were operating on his level suggests that there is a level to be operated on. And I think we need to understand that. And we need to perhaps understand that when we're doing these kinds of interventions, maybe the mechanism is the thing that we're doing in all the activities, but maybe it's an opportunity to feel connected and included. And if that's the case, if that's operative, we need to take that seriously and think about who needs, wants, is ready for something like that too. Not just who's ready to, play a round of applause or learn a lesson.
Thank you. I think it's a good time to throw it open to questions before we, the young lady right here in the front row. Do we have a mic running around?
Yeah.
What I'm wondering is, how have non-autistic people changed in the last generation or two? Because I would imagine, the ability to integrate depends a lot on receptivity and support that you get from the outside world. And this is becoming much more part of our world. So have people stepped up?
Have people stepped up? In the best case scenario, we're talking about something like inclusivity and appreciation of differences. And I wish I could say yes, all young people are more appreciative and inclusive. I don't know that I'm ready to make that claim about a whole generation. What I can say is that just looking at the research literature, there is some evidence, primarily from Connie Kazari at UCLA, suggesting that at least the current generation of kids in elementary and even school and even a little bit older can learn to be, at least, and that learning to be, and that being in an environment where, for instance, appreciation of everybody's strengths and differences. Likewise, my old grad advisor, Amori Makami, did some wonderful work in this realm as well. that doing so can really matter for the outcomes that we care about. So I'm not sure I'm ready to make sweeping claims about 2 generations of people, but I can, I think, say that I'm optimistic that people can learn, and can learn in a way that will be valuable for the folks that at least I and many of the people I think in this room care about.
Anybody else have a question for Matt? Yes, back there.
What's your take on the shift of DSM-4 to DSM-5, the merger of Asperger's syndrome with the overall ASD diagnosis?
Yeah.
So just to translate a little bit of that, ASD is Autism Spectrum Disorder, which was essentially the renaming or the co-naming of autism as acknowledging it was on the spectrum. But in doing that, we've all heard of Asperger's syndrome, which most of us have heard of it, which was always sort of colloquially said, well, sort of very, very high functioning autism. And I think what's happened, what you're alluding to, is that Asperger's has sort of been pulled out of that. Is that correct? And
Well, Asperger's has been pulled into it, actually.
Right.
It used to be.
It's not separated out anymore.
Yeah, we used to have, the category was pervasive developmental disorder, and there was sort of an umbrella, and then you could sort of have one of 5 things within it. Asperger's was one of them, and now the APA has changed that. So I think that there's a couple of sides of this. So on the one hand, the rationale of the DSM committee who made this decision was looking at the research literature and saying, can we say, is there a meaningful category that we can really call Asperger's, or is that a group of people who's meaningfully, reliably different in a clear way from people with autism who also have sort of higher cognitive ability. And the big difference, really, looking at the DSM-4 categories, the main difference between a person who's 13 years old and shows up for my group and is said to have Asperger's and one who doesn't is whether or not they had sort of intact language development before the age of like 2 or 3. And so the literature, in some, didn't appear to suggest that specific distinction meant a totally different kind of person requiring a different label. So that's on the one hand. On the other hand, I think that, perhaps this is what you're alluding to, and this has been a big issue in sort of the ASD world, is the community that has, built up around the term Asperger's, right? It's essentially become a community identity that I think very reasonably has helped individuals find a home, find, in the words of the child I was talking about, some other normal people, so to speak. And I think that is totally reasonable, and I think that one thing that's happened is there was this backlash when it was said that DSM-5 was going to sort of swallow up Asperger's and autism. They say, well, how will we have an identity anymore? How can we sort of organize as a group? And what I would say is, I'm not sure I agree with the premise of letting the APA define any community in the first place. That is to say, a person, you can, any community, I think, has a right and responsibility to define itself on its own terms. And whether the community is Asperger's or redheads or people who like to play Settlers of Catan, right? Whatever it is that forges you together and says, we are like-minded, have similar goals, or at least feel comfortable hanging out with each other and talking in the same language, that's reasonable. And I actually don't believe that it's useful to give any organization outside the power to say you can or can't call yourself that. So while I think the term as a diagnostic tool may have changed, the term as a community defining tool is totally intact, and I think should and needs to be.
We have any more questions? I think we have time for 1 or 2 more. Yes.
What about severely autistic kids and very limited language skills, etc.?
Interestingly, so this is where we sort of have more a big gap. So early in development, right, these sort of early behavioral interventions are actually sort of designed and targeted for that population. But certainly that population continues to grow up, and not all of them, some of them continue to have those challenges. So the question is, what do we do for them, right? And I would say that unfortunately, at least in the research world, that's where there's been a big gap. And actually there's a consortium right now put together by Matt Siegel at University of Maine and Carl Mazevsky at University of Pittsburgh, funded by Simons Foundation and the Nancy Laurie Marks Foundation, that's specifically, finally, like now, like literally it just started in the last 6 months, starting to look much more seriously at that population. So that's sort of my answer as a researcher, which is that we don't know nearly enough. It's a crying shame, and it's time to start focusing. Putting on my clinician hat for a second, right? Because these interventions I described, we also do clinically as well as in research context. What I would say, we have many of the sort of community service agencies and organizations are focusing on trying to improve both supports and also long-term outcomes, like vocational opportunities for that population. For those who are watching this at home or those who are here, please reach out to those kinds of organizations in your state. Many of them are state funded. And there are, for instance, in many states, insurance waivers, like Medicaid waivers, that fund at least some of these opportunities. So it's a stopgap. But I think it's not the case that there's nothing available. We just need to do a better job of studying and disseminating.
Okay, thank you. We have time for one more question. Yes, sir.
What's the most exciting thing that's happening in our field, and what's the thing that we need to really address?
I think that the most exciting thing is also the thing we need to address, which is, in this case, the really, really new idea that we can understand that there is variability within people with autism and between them. And what I mean, and I guess that in some ways that idea isn't new, right? I said the whole time, there's one person with autism, one person with autism. So what are you saying? So what I'm saying is we can actually, if we start to take seriously this notion that we can start to understand individuals in a much more sort of individualistic, person-centered way, we can understand a lot more about the ways in which they develop and the ways in which that development reflects fundamental changes, trajectories over time. So what I mean by that is, for a long time, when thinking about autism as one thing, and it's kind of there's not much you can do, and there's only a little bit of room for change. That's frustrating, for a clinician, for a researcher, for families, and it suggests that there's something really kind of intractable or stuck or concretized. And now we're starting to realize there is flexibility. There's this term that's sort of used in a lot of different contexts, perhaps inappropriately, of neuroplasticity, right? And if we just sort of accept that idea, right, that the idea is the brain is plastic, and that people with autism don't have Swiss cheese brains. They don't. They have real human brains that are plastic in the same way that all brains are, and that behavior is likewise plastic, and communities are likewise plastic, malleable. These are things that we can change and move, and then create opportunities for not just sort of surface level changes, but real lasting improvements in quality of life and happiness. That's, I think, this idea that is both really exciting, but we need a lot more in that direction before any of the things I just said can actually be, nailed to the wall.
Well, I think that's really a beautiful answer on which to stop. And because it was just very indicative of not only your extraordinary knowledge, but also your extraordinary passion about this subject. So please, let's thank Matt Lerner for a wonderful conversation. And I want to thank the Hilton Garden Inn and everyone here in the Stony Brook community. And that's it for this edition of Science on Tap. We'll be back soon. Thanks very much. Terrific.
I almost took your beer.
We have to take my beer, okay.
Cheers.